Thank you for inviting me to give that talk on post-therapeutic changes of HCC. These are my disclosures. And the most commonly used staging system for HCC is that BCLC staging system, where you could see actually that according to the stage, we have a variety of different treatments available. Actually, do we have a laser pointer? And I think you may see this better here, that in the early stages, you can use surgery or ablation or even transplantation, and in the intermediate stage B, it's mostly chemoembolization, whereas then in the advanced stages, you would use sorafenib or Nexavar, and then just a palliative best supportive care in the very advanced diseases. So, if you have a patient with a very early stage, so stage 0, stage A, what is it? Stage 0 is a single nodule, single HCC up to 2 centimeters in a patient with a good liver function or a Child-Pugh score A, and stage A would be a single or up to 3 nodules, not more than 3 centimeters, and the patient could have a Child-Pugh cirrhosis stage A or grade A or B. And in these patients, basically, you have 3 different options. You could do either a resection or an ablation. That really depends on local expertise, patient preferences. So this is quite variable in different centers. And then, of course, there's also that option of transplantation, depending on the underlying liver function of the patient and also on the availability of organs and also the underlying disease. But resection still is an option widely used. I think it's going to be less and less because we're doing more interventional procedures in these patients. But still, resection, what can you do? Actually, if you have a large HCC, you can still do a hemihepatectomy. But most of these patients would undergo an atypical resection, so a parenchymal sparing resection, because in these patients with liver cirrhosis, you really want to spare every milliliter of liver volume because the patient have usually an impaired liver function. So what are the complications or failures you may encounter after surgery? You can have, and I'll show you examples of that, incomplete resection, that you do not take out the entire tumor, and then what may happen postoperatively, if the liver function is not good enough or you've taken out too much, then the patient will have liver insufficiency, something which is not basically diagnosed by radiology. But what we are supposed to diagnose is our hematomas, biloma, abscesses, and then as a late complication, you may also see recurrence of HCC in the liver, either at the resection site or somewhere else in the liver. So here is the typical example of a postoperative defect. You see this is the preoperative CT, nicely encapsulated HCC well down there in the right lobe in segment 6. And then you see it's been taken out by an atypical resection. You see the postoperative defect. Everything's perfect and looks absolutely normal. You may have also other imaging features. If you look here in this patient where a small HCC in the left lobe was taken out, you see this is the unenhanced T1 gradient echo. Basically, obviously, sometimes because they don't need you don't use steel anymore, but you do this coagulation. You see that this is a rim of coagulation necrosis, which is quite bright on T1 and here quite dark on T2. And actually, this was just a small HCC which had been taken out. What are complications or quite a postoperative sequela you may see is our hematomas or seromas in the surgical bed, which is quite common and actually not really a complication unless they reach a certain size. And then eventually over weeks, a month, they may resolve. So for us, it's really very important for the follow-up and make a good interpretation to know the location of the tumor and to know the type of resection which had been performed in these patients. Here you have a patient with an incomplete resection. Actually, the due to, from the information of the preoperative CT, the surgeons thought that this was just a small HCC in the left lobe, and then the path report came back which said incomplete resection. So then we did an MRI post-operatively. So here you see this is the resection bed, and again this is a resection bed, and you see adjacent to the resection site, you see that high signal intensity on DWI, and on the hepatobiliary phase image, you see that tumor actually here, and this is a tumor thrombus in that portal vein branch of segment 4. And when we went back to the old CT films, we actually saw that there was a small portal vein branch which is now expanded by the tumor. Or you may see recurrence of HCC later on. You see, this is a patient with liver cirrhosis due to hepatitis C and hepatitis C virus infection. You see, this was just a small HCC which had been taken out several months previously. And you see, in this follow-up study, you see adjacent to the resection defect a small hyperintense nodule on T2, which takes up contrast and shows washout. So clearly, this is a metachronous HCC. Most likely, actually, it's not a real recurrence from the surgical bed, but has been basically come out in the adjacent parenchyma. And you see there's a second recurrence in the right lobe, which was not present during previous surgery. Real post-operative complications where patients need sometimes interventional treatment are biliomas. Here you see that quite large resection in the left lobe, low in density due to laceration of the bile duct. Quite often these biliomas are quite round and exert some pressure, and it's encapsulated. In this patient here, at that time, CRP and white blood cell count was normal, and then eventually over weeks, well, you see what happened basically, it got infected. You see there's very severe insufficiency here of the abdominal wall, and you see that broad communication between the abdominal wall and that bilioma here. And actually we tried to drain that percutaneously, it didn't work, and the patient needed second surgery several months later. Abscesses may occur because actually the necrosis of the tumor and necrosis of parenchyma is an ideal harbor for bacterial growth in these patients. Patients who have cholestasis and dilated bile ducts are at an increased risk of developing abscesses, so usually IV antibiotics are given before procedures. And what you see here, usually post-operative, you have these fluid collections, and sometimes early on you may have gas bubbles, small gas bubbles, which is quite normal. But if they stay on these gas bubbles or they increase, then you certainly have to suspect that the patient has an abscess, and clearly there are also clinical signs. Here you see an early post-operative follow-up scan, and you see that there is a small fluid collection there, which is quite normal, small hematoma, and then the patient deteriorated. That's about 10 days later. You see that fluid collection gets larger, and you see also that there are some gas bubbles in there. Quite rarely, I would say, you see really nice rim enhancement. So I think it's just the size increase, the gas bubbles, plus the clinical signs of infection, which may lead you to the diagnosis of abscess. As I said, tumor ablation is also a procedure we do now more and more. It could be either radiofrequency, microwave, or laser, and quite often you can do complete ablation, but if it's not complete ablation or you have a failure, basically you can sometimes I'll show examples of that of incomplete ablation. And then again, there is quite a good number of complications you may encounter. Again, bleeding, hematoma, cholangitis, abscesses, or pseudoaneurysms or AV fistulas if you hit the vasculature. Here's the typical post-ablation appearance. This is an avascular defect. Sometimes you may have small gas bubbles in there, again, within the first few days. And the defect you produce actually should increase the size of the tumor by a rim of at least 5 millimeters. And quite often, as you see here, this rim is typically hypervascular in the arterial phase. So this is hyperperfusion and granulation tissue. And the study has demonstrated the temporal evolution of this hypervascular rim. At 1 month after the intervention is present in roughly 90%, and 1 to 3 months still in more than half of the patients. And even after 6 months, 22% of these patients had still some hypervascular rim. But look, this rim should be quite regular and not should show any nodular thickening. Here you have a patient with a complete ablation. This is a small HCC, non-hypervascular. Don't see it well with CT, but it's nicely seen with ultrasound. So we did an ablation ultrasound guided. And you see here basically, you see this avascular defect. This is immediate post-operative radiofrequency. And here you see the 1 month follow-up in the arterial and in the venous phase. You really see that this is a completely hypovascular, avascular defect. Actually, there's no hypervascular rim, and you see that defect here is large in size than the small HCC, so we can be pretty sure that we achieved a complete ablation. Another patient with a complete ablation, you see dark on T1 pre, you see very hypervascular, this HCC, and you see it's after ablation. It's bright on T1. You have this coagulation necrosis, which is quite bright. And you see with gadolinium, it's hyper. So it's sometimes difficult to figure out, is this bright here because it was bright on the unenhanced. So always do a subtraction. So you see that there is a kind of a hypervascular rim. And you see 5 months later, there's resolution of hyperemia, and this is now just an avascular defect, so typical signs of complete ablation. What happens with DWI after ablation? You see that this is pre-radiofrequency, bright on DWI, on the B800 image. You see there is slight diffusion restriction on the ADC, and usually you see that the signal intensity on the DWI image actually decreases if you have complete ablation, and actually it's quite nice to use DWI also for looking whether there is tumor recurrence, although I think dynamic gadolinium is superior to DWI in this respect, but we always look at these two pulse sequences. Here's a patient with an incomplete ablation. You see 2 small HCC, quite hypervascular. Here, put in the needles, but obviously it worked for one, but actually the needle for this lesion back there, here in segment 6, moved during the intervention. So you see that this is the ablation defect, and you still see that a lot of that nodule being not ablated. Here you have this rim of enhancement, and then so we did a re-ablation, and you see after the second ablation, you see that there is now that defect completely encompassing the hypervascular HCC here. So sometimes you have to do it basically in 2 procedures. How can we assess our therapy? You've heard a little bit about RECIST and mRECIST yesterday. With RECIST, basically you have trouble in assessing HCC, because with RECIST, everything is about measuring a lesion, and you do not take into account whether this lesion you see is hypervascular or it's just an avascular defect. So the problem is here, if you have necrosis after radiofrequency or after TACE, that would still be counted as a lesion. You see here, this is the lesion pre, this is the lesion post. You see, this is largely necrotic. This is just residual tumor here. With RECIST, you have to measure everything. But couple of years ago, Riccardo Lencioni and his group published modified RECIST, and they said the target lesions measure the longest diameter of the viable tumor. So I have a lesion like that with a large necrosis, you don't measure this diameter, you just measure that diameter, and this is now the size of the target lesion. As you see here, you have this lesion partly being necrotic after therapy, and this is actually the size of the viable tumor, so only measure this and not the complete diameter here. What are non-target lesions with MRECIST? If you have a portal vein tumor thrombus, or if you have portohepatis nodes, which are at least 2 centimeters in short axis size. We've seen cases of patients with HCC stage 0 or stage A. Intermediate stage B are those patients with multinodular disease, could be Child-Pugh score A and B. And in these patients, typically chemoembolization is performed either with drug-eluting beads and chemo or with lapiodol and chemo. And the aim, of course, is to achieve complete devascularization, although this is not that often the case. This is one of the cases where we really achieved complete remission. You see, this is a very hypervascular HCC right up in the right lobe, and you see after 3 cycles of TACE at a 1-year follow-up, you see there's complete devascularization. If you use lapiodol, basically it's a little bit more difficult to see whether there's no enhancement, so always use subtraction in order to exclude that there are enhancing tumor nodules in between lapiodol accumulation. Here's a patient with where in one lesion we could achieve a complete devascularization, and in the other just an incomplete, because the 2 HCC of these patients were different. You see, this is a patient with a hypervascular HCC in the left lobe and a quite hypovascular HCC, which was path-proven in the right lobe. You see, this is post-TACE. You see complete devascularization of that HCC. It's shrinking again, and you see this lesion here actually doesn't change much. So we really don't know. If you look at the follow-up, you see with DWI, you see there is a slight hyperintensity here, and that actually grew 4 months later. You see that there is a massive local recurrence, which is DWI positive in this patient. So we always use DWI together with gadolinium to look for recurrences in these patients. Another patient with a partial remission, but actually subtotal remission, patient with a very large HCC. The surgeon actually would not want to touch upon. Here you see that the lesion here was very close to the portal vein bifurcation. You see first cycle large necrosis, second cycle necrosis getting even bigger, and after the third cycle you see only a very small nodule which was still very close to the portal vein, but after that actually the surgeon went in and resected and did a complete resection of that. So I think with the TACE sometimes you can have really fabulous tumor response even in very, very large lesions. What are complications? Well, large studies have shown 2% complications per patient and around 0.8% complications per procedure, because most of the patients, as I've shown, need several procedures. Of course, if you embolize too much, you can see liver insufficiency, like you may see into extended resection. You may see drug-related side effects because of the chemotherapy. You may see liver rupture, abscess formation, and then sometimes, depending on the vasculature, also depending on expertise, you may have inadvertent non-target embolization. Less than 1% of patients get cholecystitis, pancreatitis, or you may even have embolization to the duodenum or to the spleen. Here's a patient where actually you see the lapiodol actually here in the cystic artery and in the wall of the gallbladder, and this is another patient who got severe cholecystitis actually with perforation and a big abscess, but this is fortunately a rarity nowadays. In the end, just a few words about radioembolization. We are not performing radioembolization using yttrium-90. Indications are largely patients who have a low functional liver reserve, and also patients with portal vein thrombosis where you cannot do a TACE. This is a patient, actually, you see this is a pre-radioembolization, you see post-radioembolization. At 1 year follow-up, you see a complete resolution here of this tumor. Or another patient where you have a portal vein thrombosis, you would not want to do a chemoembolization in this patient, but with radioembolization, obviously, you get good response and complete resolution here of the tumor extension into the portal vein. So let me come to the conclusion. If you do a liver ablation, you should achieve an avascular defect, and that defect should be in size at least 5 millimeters larger in addition to the tumor size you're dealing with. Quite commonly, we see these hypervascular rims in the arterial phase, and they subside usually over time, but be aware that even after 6 months, you may see these rims in roughly 20% of patients. With chemoembolization, always use mRECIST for assessment of necrosis, because RECIST really doesn't take into account that how you deal with all the necrosis versus the viable tumor, which is still present. And then you should also be aware of the imaging features of the complications such as hematoma, biloma, abscess, or non-target embolization. Thank you.